A healthy lifestyle is beneficial for MS, that so far the effectiveness and superiority of one diet above the other remains unclear, but adherence to the Mediterranean diet might be promising.
I'm always told you should never say to somebody that was a great question, but these are two great questions. They're fundamental questions.
I think, Alan, that you touch upon a very important point, which is access to treatment.
It's a busy slide, but like busy slides is trying to make a point. And the point two, one that you're very familiar is that we now have lots of medications for relapsing remitting MS. But the second side, the research advances, tries to lay out some of the discoveries that have driven those treatments.
Welcome to part 2 of a 3-part series on a special ECTRIMS event held recently for people with MS. I'm Naomi Smith, and you're listening to the ECTRIMS podcast. ECTRIMS is committed to ensuring the latest research on multiple sclerosis unveiled at its annual congresses reaches the people most affected by it. In a first for the world's largest MS research organization, a special ECTRIMS 2022 event specifically for people with MS was held on the 29th of October in Amsterdam, the Netherlands. During this free event, available on-site and online, and in several languages, MS experts discussed the key insights of ECTRIMS 2022. The event was chaired by ECTRIMS President Martin Torre and the local organizing committee chair Bernard Outehaag. In part 2 of this recording, Dr. Brigit de Jong from Amsterdam UMC and Professor Alan Thompson from Queen Square Institute of Neurology in London discuss promising new short-term research data for people with MS.
Thank you very much for Brigit de Jong, who is willing to present at least a part of what has been discussed over the past 3 days. She is an assistant professor of neurology at the Department of Neurology of the Amsterdam University Medical Center and also working in the MS Center Amsterdam. Of course, I'm very proud, Brigit, that you are willing to present your selection of what has been discussed the past 3 days.
Yeah, thank you so much for inviting me. I think it's a really great honor and pleasure to speak here today for you here physically, but also the ones who are attending online. And I fully agree that at the end, the most important thing is that all the research we are doing, that we translate it back into the clinics, because at the end, the people who are living with MS should benefit from it. And today I will focus on the more short-term subjects or topics that people can do just by themselves, like, oh, what can I do, for example, tomorrow or next week? What can I do? I have no disclosures. I will present some data of 2 different trials, and one of them is funded by the National MS Foundation, and the other one is funded by MS Research. And the study on lifestyle intervention has been supported by Food Lives. When I go to a meeting and I come back in the outpatient clinic, then people ask me always like, do you have some news for me? What can I do myself? And I think in essential, they ask me how to take back control over my own health with a chronic illness. So with these kinds of questions in my mind, I visit the ECTRIMS meeting the last few days, and also inspired me to look with an other point of view to the meetings, like, oh, what's important for the people living with MS? So I decided to focus on diet, on exercise, and also whether we can modulate cognitive complaints among people with MS. And really often people in my clinic, they ask me, can I modulate my disease with a diet? And what can I do myself? And unfortunately, so far, the effectiveness and superiority of one diet above the other remains unclear. But still, then you wonder, like, are we able to provide some more guidance beyond, like, live a healthy lifestyle? Which evidence is present today? So if you look at cross-sectional data, that means that you collect data on one single time point. So you ask questions like what kind of, for example, here, diet you are taking. Then we see that people who are adhere to a higher diet quality, that these people have less MS-related disabilities and less symptom burden. With a higher diet quality, I mean that people are consuming more vegetables, fruits, whole grains, less sugar, red meat, and processed food. And we also see, also recently, a colleague of mine from New York, Ilana Katsan, she showed that adherence to the Mediterranean diet resulted, at least was related to less physical disability, cognitive dysfunction, and depression. Yeah, what's so interesting about Mediterranean diet? This already has been investigated in many chronic diseases in general. And then beside vegetables, fruits, and nuts, olive oil is really important, and moderate amounts of fish, meat, and then mostly white meat and dairy are allowed to take. And if you see in the general population, so not only for people with MS, then you see that people who are taking these kinds of diets, that there are less cardiovascular events. So these are heart diseases and blood vessel diseases, that people who adhere to this, that they have less these kinds of events, but also cancer is less frequent present, and also neurodegenerative diseases in general. And with neurodegenerative diseases, I mean diseases that cause brain damage, for example, Alzheimer's disease, Parkinson's disease, but also MS has a neurodegenerative part. But also if you look at the incidence of the risk of death due to any cause, then you see that people who adhere to this diet, that they have a lower risk. But that's, so far I spoke about a single time point. So if you look at people who are having a better diet quality, that they feel better. But then you can wonder, is there a causal relationship? Because it can also be because people feel better, they exercise more, that it's due to that they also are consuming a more healthy diet. So for that, you need to do an intervention study. And so far, there have been some small pilot studies with the maximum of 75 people. And then you see that people with MS who adhere to a better diet quality, that they have improvements of their quality of life and less fatigue. So it improves their MS symptoms. Right now in the Netherlands, there's an online lifestyle intervention study going on. We call it the LIMS study. And so far, more than 600 people have been enrolled. And this lifestyle intervention study includes, it's a secured online community, and there people are taught and also stimulated to adhere to a Mediterranean diet, but also teach about exercise, relaxation and sleep. And now we follow them over the time to see if the impact of MS on physical functioning, but also on more psychological, mental functioning, whether it improves these kinds of symptoms. As what I said, more than 600 people have been enrolled now. And since we also have a small run-in period, of 3 months, and then we have the intervention, and now we are following the people. We are able to make a comparison how the people, how they feel before they started the diet and after the intervention. And I can tell you we have some promising data, but we are waiting until all the people are finished the study. Then I'm able to really share this data with you, but it's coming up soon. But still, it's also related to to the previous talk. Then you can wonder, what's the underlying mechanism? So if you see that people improve, if they feel better, is it more related to general health changes and behavior? They feel better, they exercise more, so like for everybody that it's good? Or does it directly target the disease? And then you also can split it up between, has it an immune modulating effect? So does it modulate the immune system? Or does it also really reduce the neurodegenerative aspects of the disease, so the more damage to the brain and the spinal cord? And we also know that diet and the intake of diet, and either healthy diet or a not that healthy diet, that has influence on the microbiota. These are the microorganisms that are present in your gut, so the bacteria, viruses. And we know that depending on what kind of diet you are taking, the diversity and is changing of the gut microbiota. And some really exciting data have shown that the microbiota are really important and modulate your immune system. So it might be due to the fact that you are taking another diet that it modulates your microbiota, and due to that it affects your immune system and probably your brain as well. But we also know that, for example, in a Mediterranean diet, that was also already mentioned, that you have lipid mediators present, and they also modulate your immune system. So it might be that you can try, independent of the medication that you are taking, that you can also modulate your disease due to that. So these are really exciting experiences and data and studies that are going on right now. Oh wait, I'm going back. I will also tell something about cognitive rehabilitation and mindfulness. It's whether it reduced the cognitive complaints among patients with MS. It's entitled the Remind MS study. That was a randomized control trial, and we investigated whether cognitive rehabilitation therapy and mindfulness might reduce the cognitive complaints among people with MS. And cognitive rehabilitation therapy, there's increasing evidence that it may reduce cognitive complaints. And you can target it in 2 different ways. So you can either teach people to compensate their strategies, how to think, how to organize everything. On the other side, you really hope that you also can restore cognitive abilities, and most of the time that's tested on the computer by certain kinds of games. But most of the time, these studies are, the primary outcome is on a cognitive test. But then still you can wonder whether it also has effect on cognitive daily functioning. And we decided to focus on that mostly. Also, mindfulness-based cognitive therapy, so that's meditation and really focusing on attention, that it might have some cognitive, beneficial effects on cognitive function in MS. So we enrolled 110 people with MS, and we randomized them, like what was mentioned before, on either cognitive rehabilitation therapy, mindfulness, and enhance usual care. And we measured them beforehand, how they were doing with their cognition, but also directly post-treatment, but also after 6 months, because to investigate whether it retains. These, the intervention, the duration of the intervention was 9 weeks, and we, when you make a comparison between cognitive rehabilitation and a control group, but also mindfulness and a control group, then we could clearly see that the cognitive complaints were reduced among the people who got one of these interventions. But if you look after 6 months, then it was different between cognitive rehabilitation and mindfulness, that people who are doing the cognitive rehabilitation, they showed that they were still have a better goal achievements. So that's really something in daily life that we ask people, like, what would you like to improve in on cognitive functioning? For example, people say, when I start with a task, then really often I get distracted and I start doing other things, and at the end of the day, I didn't do what I planned to do. So my goal is that I improve to finish one of the tasks that I planned in the morning. And we saw that the people who attended these cognitive rehabilitation, that they were still retained on better having goal achievement. On the other side, that people who attended the mindfulness course, that after 6 months, they were still able to process new information faster as compared to the control group. I borrowed this slide from Ulrik Dalkas. He is a researcher in Aarhus, Denmark, because I think he really showed really nicely that with exercise we can actually reduce MS symptoms. Also in the field of exercise, there are projects going on to see whether we are able to really modulate the disease itself by doing more exercise. And some interesting data are coming up, so it might be beneficial also in the sense that it really modulates the disease itself and not only the symptoms. But these are studies that are still under investigation, but that would be great as well. So also exercise is effective in symptomatic treatment in MS. So here I would like to wrap up and share with you that a healthy lifestyle is beneficial for MS, that so far the effectiveness and superiority of one diet above the other remains unclear, but adherence to the Mediterranean diet might be promising, and that if someone has cognitive complaints, then you can consider cognitive rehabilitation or mindfulness. It might be helpful. And exercise is effective in symptomatic treatment in MS. I would like to thank you.
Thank you so much, Brigit, and please join us. And now it is my great pleasure to introduce Professor Alan Thompson. He's a consultant neurology at the National Hospital for Neurology and Neurosurgery, Queen's Square in London. He's also dean at the UCL University, and he is, I think, one of the persons who has most contributed to the research in the progression field, and he has been outstanding for all the progressive MS initiatives. So thank you very much, Alan. We are really very much willing to hear your selection.
Thanks, Mar and Bernard. Thank you both for the invitation, and I agree with the other speakers. It's really important and nice to be here, even though it is a Saturday morning, which is fine. So Brigit and I had to talk about things that had fairly immediate effect, or rather than looking to the future, and that's not so easy. But I'm going to begin by showing this slide, which is from Lancet Neurology, for those of you who want to follow up on that. This is a nice review, a short review, 2 pages, of progress in MS therapeutics. It's a busy slide, but like busy slides, it's trying to make a point. And the point are 2. One that you're very familiar is that we now have lots of medications for relapsing remitting MS. But the second side, the research advances, tries to lay out some of the discoveries that have driven those treatments. Well worth having a look through this. So what I'm going to focus on actually is really a couple of studies, and I'm going to go through 3 or 4 studies quite quickly, because 10 minutes, it flies, and I've only got 8 left now, so that's even, I don't know how that happened. Really, these are studies that are looking at data we already have and are comparing different drugs. And they really are all about trying to help us to select the right drug for the right patient at the right time. And I think quite useful. There's no absolute clear-cut answer, but the first study was actually done by a very large group, as you'll see here, led by Marcello Mocchia was the lead author, and that essentially looked at a number of drugs which we use, a number of treatments, dimethyl fumarate, fingolimod, leteriracetate, natalizumab, and ocrelizumab, and looked at it. At how they compared, and I'm not going to go into methods, there isn't time, which is probably just as well. Looking at relapses, looking at the EDSS and MRI activity. Now, in the subsequent slides, there's lots of graphs. Don't worry about them. The question is whether the lines are together or separate. And I mean, and there's usually a bottom line message. These are the large groups that were compared in that particular study, so it's fairly sizable. And when these drugs were compared in terms of relapses, it was quite clear they were looked at 1 and 2 years. That at year 1. Ocrelizumab came out better than any of the other drugs that were compared. At year 2, it wasn't quite so straightforward. Again, ocrelizumab was better than fingolimod and leteriracetate, but there were no differences with dimethyl fumarate and natalizumab. In EDSS, ocrelizumab came out best at 1 year and 2 years compared to all the others. Which it was quite a straightforward result. But with the MRI, it wasn't quite straightforward, and there were less marked differences between the drugs when you looked at new lesions developing an MRI. So the conclusions from that study, as you'll see, I'm doing it very quickly, is that ocrelizumab was associated with a higher probability to lower risk of relapses and EDS worsening when compared to the other disease-modifying therapies. I think the second point is really not so much that it showed superiority to natalizumab, but it's just that the way these results were investigated don't allow you to apply them to a single patient. And it just allows me to reinforce the point that it's clinical judgment and discussion with the patient that determines what medication they should be on and then how they should change from that as and when. So the second study, it looked at, and we've heard about stem cells. Dan did a great job of giving us background for these talks. And these are autologous hematopoietic stem cells, and this is a very large study, again led by Tom Kalanick in Australia, and he compared again existing data of looking at stem cells versus fingolimod, ocrelizumab, and natalizumab, because we have sometimes the impression that stem cells are better than anything, and they're what we all should be looking for. And this is his study cohort, quite again large numbers and complicated matching. So now again, this is busy, but it's just look at the graph. And this is comparing stem cells with fingolimod. The lines are very, very far apart, and they indicate that stem cells function much better in reducing relapses than fingolimod. This is looking at disability, and again, the lines separate in favor of stem cells. When you look at natalizumab, again at relapses, there's a gap. It's not quite as striking as with fingolimod, but it is there. There is a difference in favor of stem cells, and also particularly in confirmed disability improvement. It's actually not as large as it looks, but it's reasonable. And interestingly, and this relates back to the previous study I've talked about, when you look at ocrelizumab and stem cells, the lines are the same. So that's kind of clear. There's really little difference between these two approaches in this study. When you looked at disability, yeah, there was maybe a little bit of a difference over a period of time, not terribly striking. So the summary, one final point, as again with stem cells, we do know that they're not something you treat lightly, that they should be done in specialized centers, and that there's there are side effects. And in the studies that were looked at, that there was one treatment-related mortality. So the summary of that, basically the two lines, is that stem cells were substantially superior to fingolimod and marginally superior to natalizumab, but similar to ocrelizumab in terms of relapses. And in terms of disability, stem cells were associated with a higher rate of recovery from disability in comparison to fingolimod and natalizumab. The same group did another study, this is the third study now, on looking at secondary progressive MS and just comparing a stem cell transplantation to natalizumab. And there have been a few studies looking at stem cells and secondary progressive MS which have not been very encouraging, and I think this really just reinforced that point and suggested that we saw very little difference between these two agents, and actually the conclusion was that stem cells were not superior to natalizumab in reducing disability progression, facilitating reduction of disability, or preventing relapses. Now, in the last 2 minutes, I'm delighted to see I'm keeping to time. I just want to touch on one study. Now, Dan didn't include negative studies, and he was probably right. But there was one study of vitamin D that I thought we should just discuss very briefly because it is relevant. It was a very nice study. It was a poster which I have to say did surprise me, but I mean that the organizers of ECTRIMS know what they're doing. Apparently. I would have thought it could have been oral. We know how important vitamin D is in MS. We know that higher vitamin D levels are associated with lower risk of MS, and also that with less inflammatory activity. And these are all slides from Ellen Mowry, who was very kind, and Tom gave me his slides. And actually Ellen made a few slides for me because as it was a poster, she hadn't made any slides, which was really nice. There have been a few studies looking at randomized trials of vitamin D. These are two that are shown here. SOLAR, which compared really very large dose, 14,000 units versus placebo, as add-on to interferon beta, and really didn't show any real difference in relation to the clinical. There was a slight difference in relation to MRI. And the second study, which again didn't show any difference in terms of relapse rate. This was the VIDAMS study that Ellen led, and 172 patients randomized to higher dose vitamin D3, that's 5,000 units a day. And there's lots of discussion about what the right dose is, and versus 600, which is what she described as the recommended allowance. And again, the add-on was to glatiramer acetate, followed for clinical and radiological disease activity. They were able to make sure that patients were adhering to the medication by checking drug levels. And the bottom line, again, these lines that we look at show there was absolutely no difference between the two groups. So taking more vitamin D does not appear to have any clinical, radiological, or change on patient-reported outcomes from a higher dose to your normal dose. Also, there were no major safety events. So the summary of that study, again, just summarizing that many studies have demonstrated association of vitamin D levels and MS risk, though that's usually in white populations, not replicated in Black, Asian American or Latino populations. Again, vitamin D levels associated with greater inflammatory activity. And finally, that this randomized trial, a little bit like the earlier ones, but this is a much better study. Well, it's a good study. I shouldn't be comparing them, should fail to show any benefit. So I would just conclude by saying that, we now have a large number of treatments for relapsing remitting MS, and these studies are helping us to decide how we should select out these agents, what we should use when, and how we should make changes. So if you like, refining and working more towards this personalized medicine. Thank you very much.
Thank you so much, Alan. So, please, questions from the floor? Yes, several.
Good morning. Thank you. My name is Robert. First of all, I would like to thank you for this opportunity today, especially for patients. I think that's something you should keep continuing. Really appreciate it. I have a question or more a discussion point for Brigit. I'm curious to know that whereas in the past, if you would go to your doctor 20, 30 years ago and would say, well, I'm starting mindfulness or I'm going on a diet, do you think that's a good idea? They would probably laugh at you. And now there's a move to the more, let's call it, alternative ways of trying to help people with MS, like the ones you presented. Would you go as far as to say that these therapies could even possibly, in some patients, replace medicine?
No, I don't dare to say that. I fully agree with you that besides the right medication for that person on that moment, that you should discuss that, whether or no medication, and if medication, what kind of medication and what fits best with that person and their personal life. But I think it's important to look broader than just medication, and it's important to discuss issues like lifestyle, for example, also quit smoking, and we see that a healthy lifestyle may add something. But I'm not sure, and I don't think that it will fully replace the medication.
Yeah, there were more questions on the floor. Yes, please.
Hello, my name is Nadine Woeklik. I would like to know something about BTK inhibitors and primary progressive MS. Thank you.
Thank you.
So, I mean, this approach is a new approach, an innovative one. There's encouraging data from phase 2 trials that they might work because it's actually looking specifically at neurodegeneration. But I think we have to wait for the results of the phase 3 trials, which will be, I think, about another year. Dan might be able to add a little bit more on this. So we're all extremely hopeful that this approach will be successful, but cautious, I guess, because we've been here before and things haven't worked out quite as we'd hoped. So I think we just have to be patient for the year. And I think it's really important to wait for the results of those phase 3 trials, because things change when you get your bigger numbers and matching, etc.
Hi, everybody, and thank you for the presentations today. Birgit, my first question is to you. I participated in the Remind MS study as the mindfulness group. It was great, and I'm still having a lot of fun with doing mindfulness. You have the LIMS study right now, and are you also following the patients based on MRI activity? That's my question to you. Should I directly ask my question to Alan Thompson as well, so we can move forward after that?
As long as I can remember it by then.
Okay, then let's...
No, I can. Sure.
All right. So you mentioned the right drug for the right person on the right time, right, at your presentation. What we see in multiple countries, like I'm living in Switzerland, I was diagnosed in the Netherlands, and we have multiple like first-line therapies, second-line therapies, and right now I'm using ocrelizumab, and but I asked for it when I was firstly diagnosed back in 2013. Are we currently able to give the person the right drug on the right time? And what would you think of high-efficacy therapy first?
Yeah, it's in the LIMS trial, only questionnaires are included because it's an online study, and we are really aiming to enroll many patients. So at the end, around 750 people. So if we are planning to make also MRIs, it would be really exciting, but that will be too expensive. It's already quite expensive to enroll all these people and to offer them these online sessions. But I hope in the future also to repeat this study with a smaller group of people and then to investigate more in detail what's the mode of action. And then I will also add MRIs.
So I'm always told you should never say to somebody that was a great question, but these are two great questions. They're fundamental questions, and they're quite difficult. So in terms of accessibility broadly, we have to realize that we in Europe are in an incredibly privileged position compared to most of the rest of the world. And there are many parts of the world that have only access to interferon and glutaminyl acetate. So the discussions we have around natalizumab or ocrelizumab are academic as far as they're concerned. And in further countries, the expense of these drugs is such that even if they could access them, they couldn't afford them. So I'm in the UK when we have NICE, which is a really interesting organization to work with. I should say, so sometimes the decisions made as what's first line and second line and third line are difficult to understand. Ocrelizumab for us is readily available as a first-line drug, and we use it a lot because it's very effective. But so are many of the others. So we're guided a little bit by all these algorithms that are imposed on us, and they vary from country to country. There's a more fundamental question, which is your second one, which is, well, if you had MS tomorrow, would you like to start on something which was kind of okay, or something that was really effective? And there's an easy answer, except that the really effective ones sometimes come with a tougher side effect profile, more challenging. So there are two studies going on at the moment, as you probably know, that are trying to compare. And I say trying because I think this is really difficult. How people do if they're started with high efficacy drugs right in the beginning, or whether they have an escalation. And I think the results of those, if they're clear, and I suspect they might not be, will be helpful. But in the end, you've got the data, you've got your NICE organizations, but then you have the clinician and the person with MS. And in the end, it's the discussion between the clinician and the person with MS that is the key one. And the clinician will want to put that person on the drug that is best for them and that the person wants to be on. And that might sound a very simplistic statement, but adhering to that can be quite challenging. But in the end, that should drive everything, in my view. Thanks.
I think, Alan, that you touch upon a very important point, which is access to treatment. And we are receiving also from considerations from many people connecting from many different places where really, as you mentioned, the choices are so limited that really listening about all this comparison that you showed to us made them feel quite uncomfortable because of access. So this is something really that we should try to move forward as organizations, because really access is key for, or not access is a key problem for many people, and we are seeing this also in our comments from the audience connected.
Yes, well, I completely agree. And the problem is that most of these trials are on the average of a group of patients, and it's very hard to take an individual advice from a group effect. So it's always important to have close contact and discussions with your own doctor. And that some of these questions are raised cannot be answered without the treating physician. And I must say there are also even people willing to enter the LIMS from all other countries apart from the Netherlands. So this is very successful. So I want to thank you. Thank you very much for this part.
You've just listened to part 2 of a 3-part series of October's live-streamed ECTRIMS 2022 for People Living with MS event. Thanks everyone for listening. Part 3 will be released shortly, so please stay tuned for updates. A special thanks to the European MS Platform and the MS International Federation for their contributions to this event. The event was held in English with simultaneous translation offered in the live stream in German, French, Spanish, Italian, and Dutch. And videos with all languages can be viewed on our YouTube channel. You could read more about this topic and more on our website, ectrims.eu. Do subscribe to the ECTRIMS podcast on Spotify and Apple, and follow ECTRIMS on Twitter, LinkedIn, Facebook, and YouTube.